Hello, hello, hello. Good evening, students. Good evening.
Okay, sir.
It started?
Okay, sir.
Yes, yes, yes. Okay,
Yes.
okay. Hello, hello, hello. Good evening, students. Good evening. From where we are streaming, there was a lag, so there's some technical glitch. I think the problem is resolved now. Yeah, good evening, good evening. Am I visible to all? Am I audible to all? Can all of you? Yes. Okay. So thank you all. Yes. Flash Vanky. Yes. Okay. Great. So today we are here for a very, very important session. I want it to be a very interactive thing. You're going to have a lot of fun. You're going to learn a lot of new concepts. And we are here to discuss the 10 most expected MCQ or likely MCQs for the upcoming NEET PG 2025. Yeah, good evening, all of you. And the chat box is also working. So these are very important MCQs. They are extremely high yield MCQs. Sure, you can expect them in the exam. And I want all of you to participate and make it a live interactive session. You're going to enjoy it. And all of you can quickly note down this number where you can get in touch with me on phone and WhatsApp on this number for your personalized timetable and guidance also. Okay. And I want all of you to participate. Right, wrong does not matter. Even if you give the answer wrong, that's fine, but we are here to learn from mistake. Okay. And before we proceed, very quickly, kindly take 2 seconds to follow me on Instagram and follow me on my OGGuru YouTube channel. Every day we are putting in lot of new content, and also join on Telegram, where you will be able to get the PDF also of this session after it is over. And quickly follow me on Insta, because we are doing a lot of medical information we give every time. And quickly, all of you can also download the OGGuru app. More about the app in some time. This is for the Android, this is for the iOS. Everybody is extremely happy, and they said that, sir, among all 19 subjects, our best performance is in OBGY. For the and iOS, it is, the code is YYMSTV. And more about this, just in 3 days time, my dear student, you will become master and champion of OBGY just in 3 days time under my guidance. What is about this app, all that we'll discuss later towards the end, where you can just get in 989 rupees just the 2 month subscription. We are also giving free extension till the date of the NEET PG. So just in 3 days time, NEET PG, we've got still more than 2 months time. So in 3 days time, all of you will become champion. Yes, this class is live and it will be available jitna baad mein bhi also. Okay, so you can, and among all 19 subjects, OBGY is a major subject. 20 to 22 MCQs are surely going to come. I'm personally guiding all the students how to study, how to prepare. Okay, so more about this later on, and let us directly begin the first question for the day. Chalo, 16-year-old girl has come to us with primary amenorrhea. Breast is well developed, presence of axillary pubic hair, USG absent, uterus. What is the diagnosis? Anybody? Okay. I want all of you to answer. Short question. Every year this question is coming, and it will surely come again also. Anybody, ये क्या है? Okay. Yes. Okay. Akhilesh, all around B. Why not A? Why not B? Why not C? Why not D? When I will teach you, I will also tell you how to exclude out other things also. And now, my dear students, please understand this. The most important point is that all of you, are you aware, first of all, of the new definition of primary amenorrhea? Are you aware that the primary amenorrhea has got a new definition? Anybody? So what is the old definition and what is the new definition? So please understand this. For primary amenorrhea, the old definition was 14 years and 16 years. Okay, two ages were considered. for a patient of primary amenorrhea 14 and 16. Now this short question, this has been decreased. 14 years was in absence of secondary sexual characters, and if secondary sexual characters, I'm writing SSC, if secondary sexual characters were present, we can wait till 16 years. Now this has changed, and we are going to decrease one year. The 14 has become 13 and 16 has now become 15. So short clap if you have learned something new. So now the new definition or the latest definition for primary amenorrhea is that by the age of 13 years, if I see a girl who has not yet gotten menses and her secondary sexual characters are absent, we call it as primary amenorrhea. But if secondary sexual characters, that means breast and axillary and pubic hair, because it is thelarchy, pubarchy, menarchy, then I wait. So if breast development is present, we wait till 15 years of age. Is this understood to all of you? And now, my dear student, the most important point, that in the whole of gynecology, what is the question? So there is primary amenorrhea and also absent uterus. So please understand this. When you have got a patient of primary amenorrhea and along with it absent uterus, what are the only two possibilities? The only two possibilities to be kept in mind is RMKH syndrome, and the another one is your complete androgen insensitivity syndrome, also called as testicular feminization. Okay, is this understood to all of you? So please understand, only these two options are there. So whenever we get a combo offer which we get every year in NEET PG, you will think of either only option A or option B. Why? Because sir, in Turner syndrome, uterus is present. And similarly, in Kalman syndrome, also the uterus is present. Is this understood to all of you? Anybody, before I proceed further, Turner syndrome, what is the uterus? How is the uterus in Turner syndrome? How is the uterus in Turner syndrome? Anybody, any idea? Big, small, chotu, big. How is the uterus in Turner syndrome? वेरी गुड. ओके, सो टर्नर सिंड्रोम में यूट्रस होता है, लेकिन यूट्रस चिंटू होता है, छोटा होता है. इट इज अ अंडर डेवलप्ड और अ रूडिमेंट्री और अ हाइपोप्लास्टिक. एक्स्ट्रा इंफॉर्मेशन, hypoplastic or underdeveloped or rudimentary or a chintu uterus is there in the Turner syndrome patient. And now, can anybody tell me, RMKH, the gonads are the ovary is the gonad, and in androgen insensitivity we get undescended testes. But the most important point to be kept in mind, all of you, is you will look at the axillary and pubic hair. And can anybody tell me that sir, axillary and pubic hair in females is androgen dependent? So ovary will secrete testosterone, adrenal gland will also secrete testosterone, and they will have well developed axillary and pubic hair. And in androgen insensitivity, the axillary and pubic hair will be absent or sparse. Yes, at your level you remember absent. It could also be sparse. Mention clap if you're happy. Thumbs up. Yes, okay, but you will mainly remember absent. OG in the chat box. So please, all of you look on the board here, because it is primary amenorrhea, absent uterus. Two options already out, and since presence of axillary and pubic hair, very good, the answer is RMKH. Anybody, another name for RMKH? Mullerian agenesis. Okay. No, there's no stucking for myself. It's okay. Okay. Mullerian agenesis. Is it understood to all of you? Now, if I make a slight change in the question, can anybody tell me, if I make a slight change in the question paper, How will the answer change? If I make a slight change, and now if I say, if I say absence of axillary and pubic hair, now what is our answer, my dear student? Now what is the answer? Yes, can I get the comments in the chat box? I'm not able to step. Yes, okay. Yes, very good, Dr. Saurabh Samal. Okay, if it is absence of axillary and pubic hair, then the answer becomes androgen insensitivity. Is this understood to all of you? And one more feature in androgen insensitivity, here the axillary and pubic hair is going to be absent. And also we get a lump in the inguinal region. Can anybody tell me what is the lump in the inguinal area? What is the lump in the inguinal region? Then the answer becomes androgen. Yes, very good. That lump in the inguinal region is the undescended testes, undescended testes. And also very, so here the answer is RMKH, which is the answer because the axillary and pubic hair is present and well developed. That is the clue in the exam. And also very important, can you tell me the karyotype? Very important. Again, short MCQ in RMKH, the karyotype is 46XX, and in androgen insensitivity the karyotype is 46XY. It is actually a boy. Okay, but please understand this, at birth the genitalia look like a female, so doctor says congratulations, a girl child is born. She will wear girls clothes, girls college, girls school, height, weight, body habitus, they are perfectly like supermodels. Okay, by externally you can never say this person is having androgen insensitivity. Okay, only when you do the karyotype, फिर mystery opens up, राज खुलता है, ये तो लड़की नहीं ये तो लड़का है. It, the person is a boy with XY karyotype and undescended testes. The testes are in the inguinal region. Is this understood to all of you? Yes. Moving on to the next very important. So primary amenorrhea, absent uterus. Please keep only these two things in mind, and never in your life will you go wrong. Remember Turner syndrome, Kalman syndrome, all of them, the uterus is going to be present. Uterus is not absent. And can anybody tell me one more feature of Kalman syndrome? Kalman syndrome, what one more feature will be there? Very important. Anybody? Kalman syndrome, what one more feature is there? Kalman syndrome में the one more picture, very good, anosmia, because it is GnRH deficiency and sense of smell gets affected. Very good, Kehundi Hundi and Shaklesh, it is going to be anosmia. Okay, so please keep this in mind. Moving on to a very new MCQ, short coming in the exam. Chalo, tell me first the diagnosis. Gravida 2 para 1 living 1 has come to us at 30 weeks of gestation with pain in abdomen, uterus corresponding to 30 weeks, contractions are present. So can anybody tell me what is the diagnosis? PVYC is 1 centimeter dilated, pulse, BP normal. All of the following can be used in the management except, don't miss out the word except. Chalo, tell me, anybody? Yes. So what is the diagnosis? What is our diagnosis? D. Very good, very good. B D. Okay, okay. What is the diagnosis first, my dear student? What is the diagnosis before jumping to the answer? What is the diagnosis? Okay. So the no, beta, it's not PPROM. Sailesh, PPROM में क्या होगा? Gush of liquor. Okay. It is not preterm. Here there is only one section, is only pain. There is no leaking. There is no leaking. Okay. If there is leaking present, there is no leaking history. Leaking of liquor. Okay. So it is not PROM. It is not premature rupture of membranes. In premature rupture of membranes, there is a gush of liquor coming out. Okay. So it is your simple preterm. It is a preterm labor. Very good, Krishna Reddy. It is a preterm labor because she is complaining of pain and there are contractions present and she is only 30 weeks. So the diagnosis is threatened preterm labor or preterm labor. Now can you tell me, sir, BP normal? Why will I give nifedipine? Why will I give nifedipine? And what one more very important drug which I am supposed to give to this patient? Anybody? What one more very important drug to be given to this patient? Anybody? Why nifedipine? Sir, BP is normal. 120/80. BP normal. Why nifedipine? Why magnesium sulfate? Yes. Why magnesium sulfate? Okay, for what reason? Okay, so please understand this, that here we are giving nifedipine as a tocolytic agent. Tocolytic agent. So it is not only for hypertension. Clap if you have learned something new. And similarly, my dear student, yes, magnesium sulfate is for eclampsia. This patient does not have eclampsia, impending eclampsia, but magnesium sulfate is also a tocolytic agent. And of course, steroids are very important. We will also give steroids for the lung maturity, for RDS, for prevention of RDS. And steroids make what one more benefit? Steroids also decrease the risk of intraventricular hemorrhage. Is this understood to all of you? Similarly, my dear student, atosiban is also a tocolytic agent. Very good, Shelby. I'm coming to that also. So the answer is carbetocin. Anybody? What is carbetocin and where do I give carbetocin? Carbetocin is a new drug. Short MCQ. Clap if you have learned something new. Carbetocin is surely coming in this year. Yes, indomethacin can also be given. Yes, so steroids I will give for sure to decrease the risk of intraventricular hemorrhage and prevention. Steroids dose also I will very quickly tell you. You're going to love the trick. Okay, and carbetocin, my dear student, is a oxytocin analog. Carbetocin is what? Okay, carbetocin is what? Sir, carbetocin is a newer drug. It is oxytocin like action. Very good. It has got action like oxytocin, but what is the speciality? Yes, it is stable at room temperature. Absolutely new drug launched in India in the last 1 to 2 years. So definitely, because remember, my dear student, oxytocin has to be kept in the refrigerator. Carbetocin is a oxytocin derivative. It's a oxytocin analog or a oxytocin derivative which is stable at room temperature, so you don't need to keep it in the refrigerator. And carbetocin, very good, it is mainly used for prevention. It is mainly for prevention of PPH. Yes, it is mainly given prophylactically after the baby delivery. It is mainly used for prevention of postpartum hemorrhage. Is this understood to all of you? It has got oxytocin like action. I cannot give it. There is no role over here. The answer is carbetocin. And one more, absolutely PG level, sir, magnesium sulfate is not only a tocolytic agent. Magnesium sulfate, when given to the mother, it is for neuroprotection. Neuroprotection for the baby. Absolutely gold medal, PG level. Okay, neuroprotection means it protects the baby. Neuroprotection of the fetus. Okay, it has been proven beyond doubts that when the delivery is expected below 32 weeks, okay, if less than 32 weeks the delivery is going to happen, we will give magnesium sulfate to neuroprotect the baby's brain from developing, okay, from baby ko brain protection, neuro protection, yes, but not 20 weeks, even till 32 weeks, okay, because till 32 weeks max self can be given. So max self is two role. Max self over here also acts like a tocolytic agent, plus max self by the way will also, so max self will stop the contraction, and max self will also help the baby from damaging the brain from the effect of preterm and cerebral palsy. Protection is there. So max self is given as a neuro protection. Clap if you have learned something new. OG in the chat box, thoko tali. Okay, so carbetocin has got no role over here. Max self is for neuro protection of the baby, as well as max self is a tocolytic agent. One more role of max self also I'll teach you today in the upcoming MCQs also. Now can anybody very quickly tell me the doses of steroids? Can anybody tell me the doses of steroids? Steroids जो हम देते हैं, what is the dose? Total confusion. Every year the MCQ also comes. Anybody, what is the doses of steroids? We have got betamethasone and we have got dexamethasone. A, B. Now total confusion. Okay, ध्यान से सुनो. Clap if you like the trick. Remember the total dose is 24 मिलीग्राम. बस इतना खाली आपको याद रखना है. बाकी फिर मैं हूं ना मतलब ओजी गुरु है ना. ओके, सो A, B, C, D. B is the second alphabet. A, B, C, D. D is the fourth alphabet. So betnesol is going to have 2 doses and dexamethasone is going to have 4 doses. Thokotali clap. Now just divide this 24 milligram by 2. So you will have 12 milligram, 24 hours apart. Thokotali. And divide this 24 by 4. We will have 6 milligram, 6 milligram, 6 milligram, 6 milligram, but 12 hours apart, at a gap of 12 hours. Okay, is this understood? So beta, yes. Okay, yes. Okay, is it clear? Betamethasone is 2 doses, 12. Very good. Paracetamol prescriber correct, and Dexa is very good. Saclesh also correct, and all of you also. Is this understood to all of you? Is it clear? So this is example, morning 9 a.m. again next day morning 9 a.m. Okay, and this is like 9 a.m., 9 p.m., 9 a.m., 9 p.m. Okay, 4 doses, 12 hours at the interval of 12 hours. Okay. Moving on to a next very important MCQ, concept based MCQ, which is surely again going to come. Primigravida presents to us at 21 weeks requesting for MTP because of IUCD failure. What can be done as per the latest MTP Act? Chalo, anybody? Yes, anybody? Wrong. Okay, लिखिता करने, wrong. Okay, Saklesh, wrong. Okay, trick MCQ. Now please understand this, sir. As per the latest, okay, so all of you know, okay, sir, MTP was allowed till 20 weeks of gestation, and now it is allowed till 24 weeks of gestation. But can anybody tell me this 20 to 24 weeks limit which has been increased is for which all condition? Okay, because sometimes there is fetal anomaly. Okay, when we detect, some anomalies are detected at 21-22 weeks. Okay, so if there is any fetal anomaly or any genetic problem in the baby, or it is a sexual assault victim or a rape, or mother's life is at risk. Okay, very good, Ashish Jai for rape. And there are some special circumstances, what the rule says, some special cases, like example, if some divorce happens during pregnancy or whatever, the couple undergoes divorce during pregnancy, all these cases, then we can increase and do up to 24 weeks. Please understand this. The take home message for this is okay, for failure of contraception, which is the most important rule, one of the most common indication. Okay, if the condom has torn, condom फट गया था, you can't be sitting at home till 24 weeks. For failure of contraception, it is still up to 20 weeks only. Clap. Is this understood to all of you? Okay, is understood to all of you? Okay, so failure of contraception, still the MTP, and sure this question is coming, still MTP only up to 20 weeks of gestation. Okay, so can be done with two doctors' opinion? Wrong. Okay, after permission of hospital superintendent? Wrong. Okay, and medical board is required for MTP beyond 24 weeks. Here please remember, we are 21 weeks and the indication is IUCD failure. So by chance we can do only if there is any congenital anomaly in the fetus. Thoko tali, clap if you have learned something new. Are you getting my point? OG in the chat box, OG in the chat box, please, all of you, those who are here. Okay, if it is a congenital anomaly, then we can say yes, congenital anomaly we can do till 24 weeks. Okay, till 24 weeks we can do it. Okay, yes. Okay, is it clear? And it is IUCD failure, so it is only till 20 weeks I can do the MTP. Is this understood to all of you? आशीष जय बेटा 3 ही है, 4 ही है. Mother's life is at risk, of course you can do it. If there's any fetal anomaly, any genetic problem in the baby, trisomy 21, any rape issue, sexual assault, and special cases like if they say divorce has happened during pregnancy or the husband dies during pregnancy, like that, or the couple undergoes divorce while she's pregnant and she's 21, 22 weeks, she does not want. So these are some special cases. Okay, Ashish, is this understood to all of you? So this is extremely important. And now also tell me signature of how many doctors? Okay, consent. Whose consent is required? Consent is only of the pregnant lady. Now how many doctors have to certify? Okay, old criteria and old law and new law. How many opinion? How many RMP? How many RMP ka opinion is required for MTP? Okay, yes, but a medical board is beyond 20. Okay, so in the old criteria, till 12 weeks, one doctor had to certify, and 13 to 20 weeks, two doctor had to give a opinion. This is old. Now in new, my dear student, up to 20 weeks, only one doctor opinion is enough, and 20 to 24 weeks, two doctors have to give the opinion. Is this understood to all of you? I repeat, as per the new criteria, up to 20 weeks, only one RMP or one doctor can give the opinion that yes, MTP is required. After 20, beyond up to 24, two doctors or two RMP have to sign on the MTP form. Is this understood to all of you? Yes. Moving on to a very short MCQ. Hysteroscopy is for all of the following except. Now can anybody tell me what is a hysteroscopy instrument for? Chalo. Asherman syndrome in a patient of menorrhagia, in a patient of infertility, or in a patient of adenomyosis. Hysteroscopy. Anybody. So my dear student, please understand this, that hysteroscopy is an instrument which I put into the uterine cavity to look at the cavity of the uterus. It is not for pelvis, it is only for the uterus cavity. Somebody saying B. Okay, wrong. That means, my dear student, it is different from laparoscopy. And how it different from laparoscopy also I'll tell you. So in the hysteroscopy, this is the uterus, this is the cervix, and what is done is a telescope is put through the cervix, through the vagina into, and we are going to check for any cavity problem. Is this understood to all of you? So this is the hysteroscopy, and what all it can tell me inside the cavity. Sir, suppose inside the cavity there are intrauterine adhesions. What is this called as? Sir, intrauterine adhesions is your Asherman syndrome. Anybody? Why do we get Asherman syndrome? Why do we get Asherman syndrome? Anybody? Why do we get Asherman syndrome? Okay, because of excessive curettage or repeated curettage. Again, a very important MCQ. Yes, repeated curettage is very good. So please understand this, and this is not only, hysteroscopy is not only for diagnosis of Asherman syndrome, it is also for treatment. What treatment can I do? Anybody? What management can I do? Very good. We will go through the hysteroscopy route. All of you look on the board, and I will do hysteroscopic. See, all of you look on the board. We are cutting the adhesions. We can break the adhesions like this, and we can make the cavity normal. Is this understood to all of you? So it is for hysteroscopic adhesiolysis. Hysteroscopic adhesiolysis can be done. Similarly, my dear student, there could be, so Asherman syndrome, of course, hysteroscopy is done. Anybody? Sir, there could be a submucosal fibroid. There could be a submucosal fibroid, or there could be a endometrial polyp, both of which are going to cause menorrhagia, and I can also see the cavity and take a biopsy if from the suspicious area. So all of you look on the board. Sir, there could be a submucosal fibroid or a endometrial polyp. Clap. Okay, which also I can diagnose with hysteroscopy and also treat it. What can I do? So I can do a hysteroscopic polypectomy. Hysteroscopic polypectomy can be done, or hysteroscopic myomectomy can be done. So this all things, and of course the same thing, there could also be a septum. Very important, previous year question. Clap. Okay, septate uterus. There could be a septum inside the uterus. Okay, two image based questions are also going to come. Okay, so all those stay right till the very end. We are going to discuss also image based question now also. Okay, so this is a septum which is going to be in the cavity, and septum can also cause infertility or present or prevent the patient from conceiving. So कैसे याद रखना है? Please understand this. Hysteroscopy is inside the classroom view. If all of us are sitting in the classroom, I can see from inside. Okay, I can see all of you. So the cavity. Okay, so infertility patients also, because of the same submucosal fibroid or a polyp or a septum may also cause infertility, and they can be treated. They can be, okay, they can be treated by, okay, they can be treated, or it can be treated by cutting. What do I do for septum? Anybody? What is the management for septate uterus? Sir, I can do a hysteroscopically septal resection. We can go and we can cut the septum. Okay, we can cut the septum and make the cavity normal. See, like this. Okay, we can cut the septum, cut the septum, cut the septum. Is this understood to all of you? So clap if you have learned something new. Okay, so this is extremely important. So in all these cases, hysteroscopy is going to play a role. My dear student, the answer is adenomyosis. Because what is adenomyosis? Sir, adenomyosis requires ultrasonography or in rare cases MRI. Because sir, adenomyosis is presence of myometrial glands within the endometrial glands is the presence of endometrial glands within the myometrium. They are going to appear as cystic spaces. Okay, cystic spaces within the myometrium. Okay, is this understood to all of you? So in adenomyosis, we are going to take help of ultrasonography, Swiss cheese pattern, call it, or they call it as the Venetian blind appearance. Your radiology teacher will teach you. So USG, very rarely even MRI will be required for adenomyosis, and hysteroscopy has got no role. Okay, is all of the following. Is this understood to all of you? 5 thumbs up, then only I'll proceed further. Can I get 10 thumbs up? Then I'll proceed further. Okay. Is it clear? So, sir, adenomyosis is presence of endometrial glands within the myometrium. Okay, they are the glands within the myometrium. Okay, they are the endometrial glands present in the myometrium, which will appear as cystic spaces, okay, inside, and we require ultrasonography. Okay, laparoscopy also I'll clear, and everything will become absolutely clear. How to differentiate between hysteroscopy, laparoscopy, all of you are going to love it, the trick which I will teach you. Is this understood? Can I get 10 thumbs up? Moving on. Okay, and before we proceed further, all of you just take 2 seconds and quickly start following me on Insta, and do subscribe to my YouTube channel also, where we are putting lot of interesting content to help you for your NEET PG and the upcoming FMG examination also. And do get in touch with me on phone and WhatsApp on this number for your personalized timetable and guidance. Okay, now anybody, what is this MCQ? Okay, what is this MCQ? So for, is this clear to all of you? Yes, can I get 5 thumbs up? Is all of you, can I get 5 thumbs up? So I understood this. Okay, sir, Asherman syndrome, we are going to help, the hysteroscope is going to help us. Menorrhagia, it is going to help us. And infertility, it is going to help me. Okay, adenomyosis, hysteroscopy has got no role. We require USG or MRI. Yes, moving on. Chalo, chalo, chalo. 49-year-old patient, 49-year-old patient. Very good. Yes. 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 Very good. Very good. Yes. Sometimes the chats are getting delayed. Yes. 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 Okay. Progesterone. Progesterone. Okay. 49-year-old patient is coming to me with a 2 menorrhagia, 2 centimeter anterior wall subserosal fibroid. The next line of management is. The next line of management is. Anybody. Anybody. Okay. 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 Yeah, but in the app, we have discussed all the things about the prolapse also. Yes. Now, please understand this. This is a googly MCQ. Please understand this first of all. Those who are saying myomectomy, those who are saying hysterectomy, wrong, wrong, wrong. Why? Please understand this, and never directly projection also wrong. Please understand this. The purpose of this question is a 2 centimeter anterior wall subserosal fibroid will not cause heavy menstrual bleeding or menorrhagia. Okay, is this understood to all of you? Is this clear, my dear students? So please understand this. Here you have to think, okay sir, this 2 centimeter anterior wall fibroid is just given to confuse the student. It will not cause heavy menstrual bleeding or menorrhagia. Is this understood to all of you? Why? Because all of you look on the board. Sir, this is the uterus. This is the uterus, and चिंटू 2 centimeter लेकिन subserosal बाहर की तरफ. It is a चिंटू 2 centimeter. Now tell me, so this 2 centimeter fibroid which is there, 2 centimeter fibroid which is subserosal as given in the question paper is not the cause for this heavy menstrual bleeding, and therefore you need to keep in mind, my dear student, that there could be some endometrial pathology. There is some other thing inside the endometrium, endometrial. And anybody, what is the age of the patient? Sir, she is perimenopausal or just approaching menopause. And what is the dictum? Those who said hysterectomy, myomectomy, wrong. Why wrong? Anybody, can you tell me? Never directly go for hysterectomy. Why? Never directly proceed for hysterectomy. Why? Because, sir, if I remove the uterus, and then the histopath report comes out to be cancer, I have done an inadequate operation. Why? Because, sir, for menorrhagia, I will only remove uterus and the cervix. Very good. Okay, very good. Yes. Perimenopause lady with bleeding. Very good, Shelby and Saklesh. Okay, sir, in a patient of menorrhagia, if also I will only do a simple hysterectomy. But for CA endometrium, I have to remove the uterus, cervix, ovary, fallopian tube, lymph nodes, omentum, parametrium, all that. Okay, radical hysterectomy. तो कौन सा ऑपरेशन करना है? सादा, मसाला, सिंपल, रेडिकल, all is dependent on what the problem is. So point number 1, myomectomy has got no role. Never again directly give progesterone therapy first. That is afterwards. First I have to do a DNC or a endometrial biopsy, or I can also do, yes, very good. Okay, I can also do in this patient also hysteroscopy, which is very good. Hysteroscopy plus biopsy. Whatever I do, dictum क्या है? In a perimenopausal, एक टुकड़ा लाइनिंग का माइक्रोस्कोप के नीचे आना चाहिए. What do I mean is, please pay attention, that in a not colposcopy beta, in a perimenopausal lady, please write down, in a perimenopausal lady who comes to us with heavy menstrual bleeding, please write down, HPE is mandatory. HPE is mandatory. Why? What is HPE? Histopathological examination of the endometrium is mandatory. Why? To rule out. I need to rule out endometrial hyperplasia and endometrial cancer first. Clap. Okay. Thumbs up. OG in the chat box. So you will remember this rule, my dear student. Short questionnaire. You'll remember me on the day of the exam. Okay, sir, when I have got a perimenopausal lady who is coming to us with heavy menstrual bleeding, write down these words. Sir, HPE is mandatory. Okay, is this understood? To rule out endometrial hyperplasia and cancer. And yes, then if it is a endometrial hyperplasia with atypia or cancer, then hysterectomy, yes, you can do. Myomectomy has got no role. Myomectomy, this 2 centimeter is not causing. And then suppose there is no hyperplasia, no cancer, then even progesterone can be given. Okay, so option B, whether I will go for option B or option D will be decided after I do option A. Is this understood to all of you? After option A. Option A is the answer. Sir, first we will go for option A, DNC or histopathological examination, and then we can think of giving a progesterone or a hysterectomy only after I have ruled out hyperplasia and cancer. Is this clear? Thoko tali, 10 thumbs up. So the take home message is that in a perimenopausal lady with a heavy menstrual bleeding, either a DNC or a endometrial biopsy or a hysteroscopy and biopsy is very, very important, and then only proceed for the treatment. And HPE is mandatory. Why? To rule out hyperplasia and cancer first. Okay, moving on. Yes, image based question, virgin MCQ surely coming. What is this? Now, is this a sonosalpingography? Is it a hysteroscopy जो भी बताया? What is this blue color dye? Is it a laparoscopy? Is it a laparoscopy, tubal ligation or chromoperturbation? And what is this blue color dye? And what is this investigation? Anybody? Okay, yes, somebody is saying B, somebody is saying B. Okay, yes. So my dear student, this dye which is coming out, this blue, everybody start jumping in the OT. Blue hai pani, why? This is a methylene blue dye. Again an MCQ. This is a methylene blue dye, but what is this? Now please understand this. This I can see the uterus. All of you look on the board. This is the uterus. This is the ovary. I'm writing OV. And this what structure we have held is the fallopian tube. This is the pelvis, what we are seeing, the omentum and the pelvis. Okay, so this, my dear student, is not a sonography. Sonosalpingography is ultrasonography. And this is not hysteroscopy. Hysteroscopy, we see the cavity. Yes, this is the laparoscopy, chromoperturbation, which is the gold standard or the best investigation. It is the best investigation for tubal patency. Is this understood to all of you? If they tell you which is the best investigation for tubal patency, or confirmatory or gold standard, laparoscopy, chromoperturbation. Now please see what is done. Now all of you look on the board and see what is laparoscopy. Sir, I will put in a telescope. I will put in a telescope through the anterior abdominal wall. And what am I seeing? Please understand, saying through the anterior abdominal wall. Now total confusion clear. Hysteroscopy, laparoscopy. All of you look over here. Laparoscopy is the terrace view. You are going in the terrace. You are going on the terrace. From the terrace, you can see the road and the car from outside. Yes or no? And hysteroscopy is inside the classroom view. Now tell me this, all of you. Tell me this. If this is the uterus, I put in a telescope over here. This is what? This is a hysteroscopy in cavity. Now tell me. And laparoscopy may I put in a telescope here through the anterior abdominal wall and I see the outer surface of the uterus and the tube and the ovary. Now can you tell me in which investigation can I see the fallopian tube? Fallopian tube हमको किस पे दिखेगा? Fallopian tube will only be seen in the laparoscopy. Hysteroscopy will only see the cavity. Yes or no? Yes or no? Which investigation I will see the ovary? If there are ovaries, ये ovary है, तो ovary will also be seen with my laparoscopy only. Is it clear? So lifelong. Now can you tell me, if I am on the terrace of the building, from the terrace of the building, can I see how many students are there inside the classroom? No. Sir, is the classroom full, empty, all that can I see? No. So sir, laparoscopy will only see the outer surface of the uterus. You'll see the uterus, uterosacral ligament, fallopian tube. Okay, this is how it looks. Okay, it's exactly what the picture is. Fallopian tube, you will see round ligament, ovary, all that it will see. Okay, but can it see the septum? No. See, septum hai to kya karna? Anybody, septate uterus, what will be required? Chalo, tell me. Septate uterus, what will be required? Hysteroscopy or laparoscopy? Okay, so yes, for septate uterus, sir, I require a hysteroscopy. Asherman syndrome already discussed. So now what is done is very good. Okay, sir, while we are doing a while we are doing a laparoscopy, all of you look on the board. While we are, okay, so I have told you for cavity is hysteroscopy. Okay, now just understand how is this laparoscopy chromoperturbation done. Sir, while we are doing the laparoscopy, the assistant will take the methylene blue dye and inject it to the cervix only. The dye is injected to the cervix. Okay, through the cervix, this methylene blue dye is pushed and the dye will enter the fallopian tube and will come out, which is called, so dye will come here, come out and come out of the fimbrial end, which is called as the spill of the dye, and that will tell me that the fallopian tube is patent. Okay, so spill of the dye. Okay, yes, is this clear to all of you? So this is your laparoscopy chromoperturbation, which is this investigation. You can see this blue color methylene blue dye and fallopian tube, uterus and pelvis. Is this understood to all of you? Yes. Moving on to a very short question. Anybody? Yes. 28-year-old obese lady, prime gravida, 26 weeks pregnant only, suddenly complains of headache, blurring of vision, oliguria, BP 180, 110, albumin +4, no history of convulsions at present, no history of any episodes of any convulsion. Okay, no history, no convulsion. The next line of treatment or the best treatment, anybody, is what? Okay. B, wrong, A, wrong. Okay, now anybody, clean bold, all of you clean bold. Anybody, what is our diagnosis? What is the diagnosis, my dear student? Yes, so please understand this. The diagnosis is not only severe preeclampsia, because BP is 180, 110. No, beta, Krishna Reddy, it's not eclampsia. It's written no convulsion. So it is not eclampsia. Eclampsia is not the diagnosis. Wrong. It is not eclampsia. The diagnosis is we are 26 weeks and we are 180, 110. Yes, very good. The diagnosis is impending eclampsia. Why? Because the presence of premonitory symptoms. Can anybody tell me what are the premonitory symptoms? They are the dangerous signs and symptoms which when present in a patient of preeclampsia, it becomes impending eclampsia. And कैसे याद रखना है? Anybody? All of you have to by heart this. कैसे याद रखना है impending eclampsia का symptoms? Again mnemonic OBEG है ना? OBEG है ना? Because Dr. Punit Bhojani OGGuru है ना? O is your oliguria. B is blurring of vision. E is epigastric pain. H is headache. Thoko tali thoko. And N is your nausea and vomiting. Is this understood to all of you? So whenever I have got a patient of preeclampsia and when these premonitory symptoms are present, it become impending eclampsia. And my dear student, whenever there is impending eclampsia, delivery is the definitive treatment. The delivery has to be done immediately. That is the last day of the pregnancy. The pregnancy cannot be continued further. Okay, now आपने हिंदी पिक्चर में देखा होगा, डॉक्टर लेबर वार्ड के बाहर आता है और बोलता है हम माँ और बच्चे में से किसी एक को बचा सकते हैं. ऑल दिस इज कचरा डस्टबिन. ओके, प्लीज अंडरस्टैंड. फिर कोई बोलेगा माँ को बचाओ, कोई बोलेगा बच्चे को बचाओ, डॉक्टर बोलेगा सेव द डॉक्टर, सेव द इंटर्न. ओके, तो किसको बचाना है? तो प्लीज अंडरस्टैंड दिस के in obstetrics it is always mother first. Yes sir, the baby is only 26 weeks. Let the patient look on the board. Let the patient be 24 weeks, 26 weeks, 28 weeks, or 36 weeks? The answer will not change. The answer will remain same. The answer will remain same. Is this understood to all of you? Let the patient be 24, 26, 28, 32. Why? So we are only 26 weeks. Yes, labetalol dena hai, prednisol, but then deliver at 34 weeks. Sorry, you'll have to go to jail. Mother will die. Is it clear? Because we are only 26 weeks. If you wait, never wait and watch. That is the dictum. Impending eclampsia, never wait and watch. You cannot say, okay, 26 weeks, let me wait till 3-4 weeks, till 30 weeks, and then I'll deliver the baby. No. Never wait and watch. But when it is impending eclampsia, the most important becomes magnesium sulfate. Now anybody, why over here magnesium sulfate? Anybody? Has the patient got convulsion? No, patient has not got convulsion. Then why magnesium sulfate? This, my dear student, is prophylactic magnesium sulfate. Okay, it has been proven beyond doubt that when I will give impending eclampsia के level पे भी when I will give magnesium sulfate, it is very good to prevent eclampsia. And after giving magnesium sulfate, immediately the delivery has to be done, and write down in the brackets, delivery has to be done irrespective of weeks of gestation. Sure, short MCQ. Is this clear to all of you? Draw 5 stars. So you cannot wait till 34 weeks. Similarly, sir, I cannot wait till 30 weeks, and I cannot wait till 37 weeks. We'll have to go to jail. Why jail? Because mother dead, baby dead by that time. Magnesium sulfate, labetalol, of course, to control the blood pressure, and immediately induction of labor. D is the answer. Yes, corticosteroids can be given, shall be. Steroids can be given, but there is hardly any time for the steroids to act. No harm, we can give the steroids, but delivery has to be done, induction of labor, and delivery will be done. Never directly go for LSCS. Is it clear? And let it be only 26 weeks. माँ और बच्चे में से माँ को बचाना है. Mother is more important. So this is a patient who is having preeclampsia, but severe preeclampsia के साथ all the premonitory symptoms, as you can see, headache, blurring of vision, oliguria. So the diagnosis is impending eclampsia, and delivery is the definitive treatment. So you cannot wait. It's not that sir एक बार Maxelf दे दिया, then I will wait. No, after Maxelf, delivery has to be proceeded for. Okay, and induction of labor. Beta, you will induce the labor first. Anyway, 26 weeks baby, very difficult. So you can induce the labor first. If the labor is not progressing properly, then you can do LSCS, or how the delivery will depend on case to case basis. Okay, is this clear to all of you? Yes. Okay, beta, all the types of students are there, so we need to give everybody the time to understand. And now moving on to the next MCQ. Tell me the diagnosis. Okay, is this clear? So impending eclampsia, never wait and watch, go ahead for the delivery. Okay, 30. Now again tell me the diagnosis first. Okay, we have got a patient who has come at 38 weeks with bleeding PV. Okay, with bleeding. Okay, so what is the diagnosis? Anybody? The diagnosis is, please pay attention, whenever I have got a patient who is bleeding in the third trimester. Why I'm saying T3 third trimester? Because 38 weeks. Again, there's anybody with the answer? Okay, so yes, two things have to be kept in mind, sir. Either it is placenta previa or it is abruption, both of them. And the most important point, sir, placenta previa is a painless bleeding, and abruption is always painful bleeding. And one important point here, the uterus is relaxed. And here, yes, the uterine tone is increase in uterine tone, or a tonically contracted uterus. Okay, tonically contracted uterus. Is this understood to all of you? And remember, my dear student, in a patient of placenta previa, the placenta is in front of the presenting part, so the fetal head, the head will not get engaged. The head is unengaged. Why? Because the placenta will prevent the head from getting engaged, which is called as a floating head. Okay, floating head or an unengaged head. That is also a very important clue in the question paper. So now, can anybody tell me the diagnosis? Yes, sir. The diagnosis is painless bleeding, uterus relaxed, and head floating. This is placenta previa. Is this understood to all of you? Fetal heart sound normal, 140 per minute. Now what will I do? Yes, malpresentations could be common. Malpresentation could be common. And also one more point, remember, initially, very important, the blood pressure is initially normal. Okay, but abruption, what is the etiology? Sir, preeclampsia. Preeclampsia or hypertension will lead to abruption. So initially the blood pressure is going to be high. Of course, after a lot of bleeding, patient will go in shock and the BP would be down. But initially, if the BP is high, think of abruption. Here the blood pressure will be normal. Is this understood to all of you? Is it clear to all of you? Yes, yes, yes. So now what are we going to do? Sir, please understand this. How many want to go for option number B, induction of labor? Jail. How many want to go for forceps delivery? Jail. Why? Because, sir, please understand this. Baby placenta फाड़ के बाहर नहीं आएगा. फटा placenta, निकला hero. Not possible. Or heroine. Okay. So baby cannot perforate through the placenta. And in placenta previa, please understand this. Yes, I will have to always go and do LSCS. LSCS will be required. If you induce labor, there's going to be more bleeding. You'll have to go to jail. Okay. So never ever induce labor. Okay. In placenta previa, never go for induction of labor. And my dear student, look at the weeks of gestation. We are already, sir, but mother is stable. Yes, mother is stable. Hemoglobin 11, BP 120/80. Baby is also normal. Then can anybody tell me why not wait and watch? Why not wait and watch is the answer. Chalo, trick MCQ. Because, sir, we are already more than 37 weeks. So there is no point waiting further, and LSCS is the answer. Is this understood to all of you? Yes. Can anybody tell me, when I wait and watch in placenta previa, what is it called as? And please comment in the chat box and go and see my video also on my YouTube channel. I've explained to you the condition. It is called as McAfee and Johnson regime. Okay, McAfee and Johnson regimen, where we can admit the patient, give her steroids, give her bed rest. But that would be the answer. Anybody, if the question paper was 34 weeks, 35 weeks, then the answer will be wait and watch. Is this understood to all of you? Okay, if it was 34, 35 weeks, then I can wait and watch for the baby lung maturity. But when I want to wait and watch, the mother should be stable. Okay, mother should be stable. Then only you will wait and watch. Yes, mother should be stable. Plus, of course, there should be no fetal distress. Common sense. If there is fetal distress, wait and watch for what? For the baby to die. If the mother is in shock, wait and watch for what? For the mother to die. No, then you don't wait. Okay, so if the mother is stable, plus the fetus is also stable, which is the case over here, and we are 34 weeks. So एक digit answer change कर सकता है. Clap if you are happy. Are you understanding, my dear student, the importance of weeks of gestation? If instead of this, chalo, tell me, if instead of this 38 weeks, I make 33 weeks as the question. Now what is the answer? Same MCQ, 33 weeks. Now tell me the answer. Yes. Sir, if it is 33 weeks, then the answer is wait and watch. Is this understood to all of you? We'll go back to the original question so there's no confusion. Yes, 38 weeks hai. Sir, now there is no point in waiting. Okay, because you are sitting on the time bomb. Diffuse the bomb before it explodes. Remember placenta previa, my dear student. आप time bomb पे बैठे हो, वो कभी भी फटेगा. So at 37 weeks only. In fact, LSCS should be done at 37 weeks only. Here the doctor, probably patient did not come on time. Why did the patient reach till 38 weeks? Okay, but 37 weeks पे LSCS कर देना चाहिए. Is this understood to all of you? Yes. Okay, 33 weeks, then wait and all. Very good afterwards. Okay, moving on. So this is painless bleeding, uterus is relaxed, this is placenta previa. The deliver is always by LSCS only in placenta previa, when you have to think in mind. Moving on to the next MCQ, again a very important clinical case scenario. What is the diagnosis? A patient has come to us with 2 months amenorrhea, UPT positive, so she is pregnant. Transvaginal sonography, uterus empty, but endometrium is thickened. Why endometrium should be thick? And there is a 3 by 3 centimeter right-sided mass with a beta H level of 1890 and pulse 80 per minute, BP, hemoglobin. What is the most suitable modality? What is the diagnosis? Anybody? Chalo. Yes, my dear student, whenever the patient is in the first trimester and the urine test is positive and uterus empty, okay, uterus is empty, okay, what am I to think? Yes sir. Okay sir, when I have a patient who is pregnant but uterus empty on sonography, uterus empty on ultrasonography, that means sir this is the uterus and there is nothing seen inside. Endometrium could be thickened because of progesterone. Endometrium will be thickened. Yes, it is a very introduction or ectopic, but here clearly, okay, now please understand this. This is your, what is this? Right-sided mass of 3 by 3 centimeters. Or on the right side or on whatever side, there is a 3 by 3 centimeter mass seen and the HCG is positive. This is a ectopic pregnancy. But can you make the diagnosis better, my dear student? Unruptured ectopic pregnancy is the diagnosis. Clap. Why am I saying unruptured ectopic? Because her pulse, BP, hemoglobin, patient is stable. Patient is a stable patient. Very good. You will not repeat USG after 2 weeks. Again, you'll have to go to jail. In that 2 weeks, the ectopic will rupture. Ectopic will rupture. Okay, if at all, my dear student, yes, e-governance, that is you repeat beta HCG after 48 hours if nothing is seen. Okay, is this clear to all of you? If nothing is seen, that means sir the uterus is empty, plus nothing is seen outside also, nothing inside, and only beta HCG is positive, then you will repeat beta HCG after 48 hours. Okay, clap. Because then you will check for the doubling time and that also repeat it after 48 hours. Okay, not repeat after 2 weeks. Okay, is it clear to all of you? Because in that 2 weeks ectopic will rupture and absolutely surgery is not required. Why? Because no, after 40. Okay, because this is a patient where methotrexate injection is going to work, which is the answer over here. And can anybody tell me the criteria for methotrexate? Okay, surgery is done in cases of ruptured ectopic pregnancy, we go for immediate surgery. Okay, IM. Okay, IM. Injection methotrexate, not IV beta, IM. Okay. So I repeat all of you, okay, when there's a confusion, okay, sir, uterus is also empty and outside the uterus also, nothing outside also, nothing inside, nothing outside, there's a confusion. Okay, where is the pregnancy? Andar hai, bahar hai, there's a confusion, you repeat beta HCG. Is this understood to all of you? There is a confusion. Here my diagnosis is clear. We have got a 3 by 3 centimeter mass. Okay, no, beta, injection I. Yes. And can you tell me what is the criteria for ectopic for giving methotrexate? So the criteria for methotrexate is what? Methotrexate, sir, point number 1, patient should be stable, which is the case over here. Very good. And gestational sac less than 4 centimeter, which is the case over here. Okay, यहाँ पे कितना है? 3 by 3. Now please don't multiply 3 by 3. Don't say, sir, 3 by 3 is 9 centimeter. Is it 9 centimeter? Wrong. Okay, multiply नहीं करना है. Okay, 3 by 3 का मतलब है 3 by 3 का मतलब है, sir, one side is 3 centimeter, other side is also 3 centimeter. Basically, it is less than 4 centimeter only. Okay, less than 4 centimeter. And very good, the HCG level is also only around 1900 and your HCG should be less than 5000. 5000 micro international units. So short question, stable patient and preferably cardiacally absent. Very good. This is our unruptured ectopic with all the criteria for methotrexate satisfied, and therefore methotrexate is the answer. Clap if you have learned something new. Okay, is it clear to all of you? Yeah, those are the levels of HCG beta. Transvaginal 6000 nahi beta, Saklesh. Transvaginal at 1000, 1500 only, okay? And transabdominal pe more than 5000 the sac should be seen. Methotrexate injection is the answer over here. Okay, surgery is done in cases of ruptured ectopic. Okay, and what is this image based question? Again, a short MCQ. Chalo, tell me the answer. We have got a patient which is having a cyclical abdominal pain, urinary retention, yes, very simple my dear student, and primary amenorrhea and tense bulging hymen. Yes, this is imperforate hymen. Okay, now can anybody tell me, suppose if this picture is not given, then two options are possible. Suppose this picture is not given to you, then which two options are possible? Okay, B and C. C to hai, and one more condition. Yes, why not A? I'm coming to. Yes, very good. Okay, even your transverse vaginal septum, because what is this, my dear student? So this is a patient of cryptomenorrhea. Cryptomenorrhea means hidden menses. Okay, cryptomenorrhea. Okay, so my dear student, please understand what is this, sir. Whenever there is a imperforate hymen, the hymen is absolutely blocked, then what will happen, my dear student? Whenever the menses will start, the menses will start to come out, but the blood will not come out. The blood will get collected inside the vagina. What is this called as? So this is called as hematocolpos. This is called as hematocolpos, and the blood will further get collected inside the uterus, which is called as hematometra. And the clue in the question paper, cyclical abdominal pain. Whenever we get, because patient will get a cramping pain. Yes, every time menstrual cramps hota hai, patient gets that menstrual cramps, but nothing is coming out. So primary amenorrhea, my dear student, and this cyclical abdominal pain. And can anybody tell me why is there urinary retention? Why urinary retention? Sir, this, okay, this hematocolpos can compress the bladder and can cause urinary retention episodes. Okay, yes. And Yes, the blood can even go backflow and risk of endometriosis, all that, and tense bulging hymen, and therefore tense bulging hymen, and therefore imperforate hymen because of this picture showing us bulging hymen. Bulging hymen. Is this understood? And what is the treatment? Sir, cruciate incision you will do on the uterus, on the hymen, and you will let the bulge, let the this, okay, so cruciate incision, a cross incision is made, and all the blood will come out. One more condition, yes, one more condition, transverse vaginal septum. Yes sir, all of you look on the board. So if it's a transverse vaginal septum, not longitudinal, then transverse vaginal septum also, there will be similar situation also. Okay, sir, if it's a transverse vaginal septum, then it can also cause transverse vaginal septum. It can also block. Basically, cryptomenorrhea is when there is outflow obstruction. Outflow obstruction. Is this understood to all of you? So in that also there will be, yes, transverse, here also the blood will get collected, and there will be your hematocolpus, hematometra, all that will be same. Okay, but this bulging hymen will not be there. Yes. Okay, so because of this picture, we are marking C as the answer. A can also cause cryptomenorrhea. Okay, but then the bulging, yes, very good, but then how will you differentiate? Sir, hymen will not be bulging, hymen will be normally appearing, and then you might see when you put in, you'll have to cut the septum. Okay, you'll have to cut the septum, you have to go and cut this septum. Okay, you have to go and cut this septum. Is this clear to all of you? So transverse vaginal septum may be same hoga, hematocolpus, hematometra, and outflow obstruction, and cryptomenorrhea, and primary amenorrhea. But sir, here because of the bulging hymen, the diagnosis is not a transverse vaginal septum. The diagnosis is our imperforate hymen. Clap if you feel happy. Okay, is this understood to all of you? Thumbs up, Toko Tali. Okay, and all of you see this beautiful notes you're going to get in my app. Absolutely simple, all colored images, all integrated, and every student has told me, okay sir, just in 2 hours we can revise the entire handwritten notes. All of you get in touch with me on phone and WhatsApp on this number, and I request you that only in 3 days time, just 30 hours, 15 to 16 hours, you can see the main all MCQ. This 1.5 hour video has given you so much knowledge. Imagine when you do 16 hours, question answer, and few important topics which I will tell you where to guide, just in 989 rupees, 2 months course starting from now till your entrance exam. Will also be giving you free extension till 15th of June. So just in 989 rupees, you can take, you are going to get rapid revision MCQ videos, the main theoretical videos. Don't worry, you don't have to see all, and only 40 hours are required, 30 hours. That means in 3 days time, my dear student, you can master OBGY. Master your OBGY, and you will tell me, sir, among all 19 subjects, you will tell me, okay, sir, among all 19 subjects, my best performance is in OBGY. Is it clear to all of you? That is my guarantee. Every other students walk out, and if with your current knowledge, my dear student, if with your current knowledge you are getting 10, 11, 12, 13 MCQs correct, after seeing my videos for 30 hours, you will get 18, 19, 20 MCQs correct. And I don't need to tell you the importance of 6 to 7 MCQs more. That means 28 marks. It could be the difference between score of rank of 400 and 40,000, or a rank of 1,000 and 1 lakh. Okay, my dear student, so get in touch with me on phone and WhatsApp on this number, and just subscribe the 2 months masterclass only in 989 rupees. You will be able to revise the entire OBGY in just 30 to 35 hours, of course, under my guidance. Thank you, Otoko. And this is the app which you have to download, the OGGuru app, and Masterclass NEET PG is the name of the course, and the subscription, this is for Android and iOS. For iOS, put in the ORG code YYMSTV. Okay, and as I said, just 2 months package you take, you're going to get beautiful handwritten notes, mock test, of course my timetable guidance, and you can see the videos at 1.5 2x speed. Of course I'll tell you which are the most important videos to see and which videos you can skip also. So just totally if you dedicate 3 hours, and there are 2 months for the exam, definitely OBGY is a major subject. 20 to 22 MCQs are going to come, so 3 days time you should dedicate to OBGY, and in 3 days you will become champion of OBGY is my guarantee. Okay, my dear students, so do download the OGGuru app, get in touch with me for whatever guidance you want, and the master class includes the rapid revision also. Okay, so this rapid revision MCQ videos and the main theory lectures, which one to say I'll guide you, and this also, do not forget to subscribe to my YouTube channel, where I have recently put in a video. It has got super, lots of views are there about the recent and the top topics in obstetrics, gynecology. Also new videos will be coming in, and thank you Dr. Bhanu Prakash channel for giving me this opportunity, and I'll be back with many more sessions on this channel also, as well as on my OGGuru OBGY channel for YouTube, and on Insta follow me also. Thank you very much my dear student, it was lovely having you all of you will do very well in your exams. Bye bye, best of luck, and thank you very much, and get in touch with me on WhatsApp on this number for your personalized timetable and guidance. Best of luck.